Hi, I'm Dr. Chris Armstrong, one of the emergency registrars here at Royal Perth Hospital, and this is this week's 5 on Friday. This week we're going to talk about paediatric trauma. Now, thankfully for most of us, paediatric serious trauma is rare, but it's still a major killer, especially with the advances in medical care and immunisation. Is now one of the major killers of young children, and so it's something that we need to be ready to deal with should the worst happen. Now, children are not small adults, and they are very different, and they also differ by age, so young children being different from older children. And their pattern of injury is markedly different compared to adults. On top of that, they present with differing signs and symptoms compared to what we would be expecting to see in adults. And so we have to be alert that what a child is displaying may not truly represent how seriously or unwell they are in reality. Now, the best way to approach paediatric trauma is still our standard ABC approach. Now, because we're thinking about serious trauma, these days we're thinking about ABC. So first of all, stopping catastrophic hemorrhage. So obviously any serious external hemorrhage needs to be stopped, and then we'll have a look at our ABCs. Now, airway in children is slightly different. Helpfully in trauma, we're just going to rely mostly on our jaw thrust to open airways, but just remember, very young children have much larger heads, so sometimes if they're laid flat on their back, their head will go down and they have a chance of obstructing their airway. So just be aware of that and concentrate on your jaw thrust to get that airway open. Now, from a breathing point of view, children can sustain quite different injuries compared to adults. Their chests and their ribs are much more pliable, they're much softer than in adults, and so they don't provide protection to the lungs as much as an adult rib cage does. On top of that, the ribs, because they're soft, will tend to bend rather than break, and so that force when they're hit potentially by a car, thinking about a child chest being about the height of a car bumper, depending on the age, that force will be transmitted through to the lungs, and so they're much more likely to sustain severe pulmonary contusions or pulmonary hemorrhage without necessarily showing that on the outside, so they may not have obvious rib fractures. If they do have rib fractures, that implies a very significant force to be able to break those soft ribs, and therefore you need to be very concerned that there is serious intrathoracic injury if they've been able to fracture ribs because of the force. Their respiratory rate can be different compared to adults. Obviously it can be raised because of pain and fear, and it can be raised in the setting of no chest injury, for example if there's hemorrhage, and that takes us on to our C assessment as well. Now, children have unreliable indicators compared to adults, so a high heart rate again may be caused by fear or by pain, and a blood pressure will often be maintained until the very end and will only start to fall in those last moments before the child goes into cardiac arrest. And I'm sure most of us who have dealt with unwell children in the past have been caught out that way before. So perfusion is the main thing that we want to look at. So it's really important to assess children how they're peripherally perfused, are they warm or cool, and importantly their central capillary refill time, so over their sternum, is it less than 2 or 3 seconds, or do they have a prolonged capillary refill time, indicating potentially hypovolemia or other forms of shock. Now, from a bleeding point of view, children can bleed in many places, just like in adults, but we have to be very aware of intra-abdominal bleeding in children. Children have much thinner abdominal walls, so don't have the protection like adults. They also have relatively larger organs, so a larger spleen and liver compared to an adult, and it doesn't have the protection of the rib cage because of a flattened diaphragm, so they're actually sitting below the rib cage, and also they have that soft rib cage, so that force will be transmitted through. So you have to be very alert. Children are also prone to very specific injuries, for example, handlebar injuries. So if a child goes into a handlebar on their bike or on their scooter, they can sustain pancreatic or duodenal injuries because of the fixed duodenum. And that can often present with a sort of non-specific abdominal pain in a child that seems unwell without any obvious bruising or anything obvious to see on the outside. So always be very aware that intra-abdominal injuries in children can present in an atypical fashion, and just because there's not significant injury or bruising to the outside doesn't mean that they're not going to have that injury on the inside, and we need to be really careful. Obviously, pelvis and femurs need to be assessed as in adults for signs of hemorrhage as well. From a disability point of view, it's easier to use AVPU in children than GCS. The differing ages makes GCS difficult to remember and assess in children. So just an assessment as to whether they're alert, whether they're responding to voice, pain or unresponsive is helpful as their initial D-assessment. Remember, children can behave in different ways, again, when they're frightened or scared or away from their parents, and that does make it difficult, so you just have to be aware and be alert for an injury. And in very young children, you can sometimes see signs like a bulging fontanelle or something if you have an obtunded child who has intracranial bleeding, but again, that's a difficult one, you just have to be alert. So in summary, just remember that children are not small adults. They have differing patterns of injury and they present in different ways, and are much more susceptible for differing heart rate and blood pressure depending on pain and fear, and that makes it unreliable. Have a high index of suspicion for injury depending on the pattern, and that's what makes history so crucial when we're dealing with paediatric trauma. And when it comes to handing over to us in hospital, we're really keen to know exactly what happened and when it happened, and at what level they've sustained injuries and what you saw at scene, because that will help us with our index of suspicion, which is really the most important thing when assessing children, because they can present in such a variety of ways and hide or mask underlying injuries in a way that adults wouldn't. That's your 5 on Friday.